Welcome. Today, you're not just watching an explainer. Nope. You are a surgical candidate, and this is your consultant-level oral exam. The topic, a classic, hypercalcemia. Let's see if you've got what it takes. So picture this. You're in the hot seat. I'm your examiner. For the next few minutes, it's all about proving you're ready for that next step. This isn't just about textbook knowledge. It's about showing me you can think clearly, logically, and safely, especially under pressure. Ready? Let's begin.
All right, candidate, listen up. I've got a new referral for you to take a look at.
And that's it. That's everything you get to start with. Just a single out-of-place lab result for a patient who seems perfectly healthy. The clock starts now.
Okay, so let's start right at the beginning. How you kick this off is going to set the stage for everything that follows. So tell me how you're going to proceed.
So talk me through it. What's your thought process right now? What are the very first questions you're going to ask her? Are there any red flags you're specifically looking for? And what are those subtle little clues that might help you start building your differential diagnosis? Excellent. So you've gone and seen the patient, and this is what you've found. She feels totally fine. You've smartly ruled out any family history of things like M&EN syndromes. You've also noted her recent surgery and that PPI she's on could be relevant. But here's the kicker. Your physical exam is completely normal. This is so important. It means we're dealing with a diagnosis based purely on biochemistry, not on what the patient is telling you or what you can feel. Okay, now that you have a solid history and physical under your belt, it's time to bring in the big guns. Let's use some investigations to whittle down that big list of possibilities to a single concrete diagnosis.
The cornerstone question. Answering this well is going to show me the breadth of your knowledge, so lay it on me. What are all the things that can make someone's calcium go up?
Now, that's a very solid list. Of course, hyperparathyroidism and malignancy are going to be right at the top, since they're the most common. But I'm impressed you also remembered the less common stuff, like milk alkali syndrome, especially since she's on PPIs, and that really important genetic condition, FHH. This comprehensive approach is exactly what an examiner is looking for. Good. You've got your list of suspects. Now, how are you going to work through it? What specific blood tests, what imaging studies are you going to order to prove what you think is going on? And just as importantly, rule out the others. And here are your results. What's great about this is how the data just tells the story for you. You've got high calcium with a high parathyroid hormone. That's the classic picture. See, normally, high calcium should be telling the parathyroid to quiet down, to stop producing hormone. The fact that it's high is totally inappropriate, and it points the finger directly at the parathyroid glands. You wisely checked the urine calcium to rule out FHH. That's a key step, because that's a condition you absolutely do not operate on. And finally, your localization scans, they've zeroed in on the culprit. Exactly. You've worked up this patient perfectly and landed on the definitive diagnosis, primary hyperparathyroidism, all thanks to one little rogue parathyroid adenoma. Fantastic work. But don't relax just yet. This exam is far from over. All right, now we get to the fun part, the surgery. Getting the diagnosis is one thing, but planning a safe and effective operation, well, that's a whole other ballgame. Let's talk about your preoperative plan. Before you even dream of picking up a scalpel, what are the critical safety checks, the conversations, the logistics you have to nail down? This is all about being a safe, professional surgeon. Perfect. This shows me you're thinking systematically and safely. You start with the patient, which is always the right answer. That pre-op vocal cord check? Absolutely vital. It gives you a baseline, just in case that recurrent laryngeal nerve gets bruised. Your plan is focused thanks to those scans. And of course, you've covered the basics of admission and consent. You're ready for the OR. Okay, the lights are bright, the patient's asleep, and you've made your incision. Now comes the real test of your anatomical knowledge and your surgical judgment. You're in the neck. Everything looks kind of the same. It's all small, delicate, and incredibly important. You see a few things that could be the adenoma. How do you know for sure what you're looking at? What are the visual clues you're relying on? And this is just brilliant. It really highlights the key differences. This is pure surgical anatomy, the kind of thing you learn from experience. That golden brown color of the parathyroid is totally classic. And that description of it popping out from the fat, that's such a real, accurate surgical sign. Knowing this is what stops you from accidentally taking out a lymph node or doing an unnecessary thyroid lobectomy. Okay, so you've identified the adenoma, it looked right, it was in the right spot, and you've carefully removed it. You've sent that crucial blood sample off to the lab for the intraoperative PTH level to confirm you got the job done. And now, you wait for the phone to ring. And there it is. The PTH level has absolutely tanked. A drop of more than 50% from your baseline is what we consider a cure. You've hit a 60% drop. That's a home run. The data is in. The lab has confirmed what your eyes told you. You've been successful. What do you do now?
Correct. That's the word I was looking for. Terminate. You have biochemical proof of a cure. There is absolutely no reason to go exploring the other side of the neck looking for other glands that are probably just fine. You did what you came to do. Time to ensure everything is dry, close the wound, and the surgery is over.
The operation was a textbook success. But your job as a surgeon doesn't end when you put the last stitch in. The post-operative period, that's just as critical. So you're writing your post-op orders, briefing the recovery nurses. Of all the things that could go wrong, a bleed, a nerve injury, infection, or that tricky hungry bones syndrome, which one are you watching for most closely in those first few hours? Thinking about this, anticipating the next problem, that's not just what a surgeon does. That's the mark of a consultant. And by the way, you've passed.